question I think perhaps some of us would like to know is it passed down through the family in any way?
Weakly, yes. Particularly, you can develop Alzheimer's when you're very young, and that's quite strongly inherited. But the Alzheimer's you get in old age, it does run in families, but weakly. So there's obviously some interaction between your genes and your environment that we just don't understand yet. No.
If you have a friend that you suspect has dementia and you're not a relative,
Yes.
and the relatives live far afield, how do you go about trying to get the diagnosis? Because you come up against the Data Protection Act and the patient confidentiality.
But patient confidentiality is one way. So the GP can't tell you anything, but you can tell the GP whatever you like. So you speak to the friend first and try and persuade them and say that there is medication available, why don't you just get your memory tested? You know, if there is anything, we can slow it down. So that's obviously the best way. If you can't, you can tell the GP anything you want, and they will read. You know, if you write to the GP,
You've done that already.
You've done that, right? So probably the GP has tried and the person has refused. If somebody completely refuses to accept that they've got dementia, there's nothing you can do until they get to a state where they're dangerous to themselves. You said the family's far away. Have you been in touch with the family?
Yes, we are in touch with them.
And have they tried as well?
Yes, but one is two are in South Africa and the other one is the nephew in Bristol.
Are they girls in South Africa? Or?
Yes.
I have to say, women,
sisters, yes.
Right, women are much better at this than men. So if somebody's got a daughter, normally eventually they are dragged to see somebody. And a very typical scenario I get is we get phone calls saying, you know, I'm back from South Africa for 2 weeks, my mum's got dementia to see us before I go back to South Africa, which I do. Right. So I would try and get one of the daughters to, presumably they do come and visit occasionally. Yeah.
To you,
We've seen on previous lectures that mental health can be affected by social circumstances. Does that also apply to dementia?
Do you know, that's a really interesting question that I don't know the answer to. No one's ever asked me that before. Do you know, Reggie? No? We'd have to look it up. Yeah.
Always a bonus.
Yeah.
good.
Good question.
We have one more question and then
I recently lost a friend, an elderly lady who had dementia. She was in a care home and she lost so much weight so quickly. And I think part of the thing was that if they asked her if she wanted anything to eat, she said no, they couldn't force her. Is that right?
Yeah. No, you can't force people to eat. You're not allowed to force people to eat, and practically you can't force people to eat. So there was a time when there was a bit of fashion for you can put tubes directly into people's stomachs and feed them. And there was a time when there was a fashion for doing that with people with dementia. I really didn't approve. It's a horrible thing to do. They didn't understand what was going on. And then somebody did a bit of research showing that it didn't prolong their life anyway. So that's not done anymore. But some people, everybody's different, but some people with advanced dementia do just stop eating and there isn't anything you can do about it.
I'm sure you agree with me that we've had a fabulous half an hour with Professor Wendy, President of the Royal Wendy is going to be with us for the rest of the evening, so if you have anything that you might want to ask her, feel free to do that in the talks. It's again a privilege to introduce the next speaker. Dr. Gina Hara is the National Clinical Director for Learning Disability for NHS England. She again, like Wendy, has been a practicing clinician, a consultant psychiatrist for several years, and I'm not specifying the number of years again. And again, I mean, that is one of the highlights of this afternoon. You have people in influential positions who continue to remain practicing clinicians, and therefore are affected with what happens on the front line of the heart.
Great, thank you very much, and thank you so much for inviting me. I'm really pleased to be here. I'm also really pleased because you're really including people with learning disabilities in your program, which I think is fantastic, as well as obviously dementia and autism, and people with substance misuse. So I think it's a really inclusive program, which is brilliant. Reggie's asked me to speak about learning disabilities from a national perspective. So in my role in NHS England, I am the National Clinical Director, and so I give clinical advice to NHS England about what we should be trying to do from a national scale. And I've based my talk on 4 key questions that I want to pose, and then hopefully I'll answer, but maybe I'll ask you as well. Have a bit of audience participation, hopefully. So I'm going to talk for about 10-15 minutes and then open up for questions anyway. So my first question is, what does it mean, learning disabilities? The first thing is that it is not a mental illness. And the second is that nor is it a specific learning difficulty. So it's not what educationists might call dyslexia or specific learning problems. But rather it's a global impairment of intellectual cognitive functioning. And this global impairment needs to be evident in childhood when the brain is still developing. So I often get referrals to see somebody with chronic schizophrenia, where in fact their cognitive functioning deteriorates because of the chronic schizophrenia. That's not learning disabilities. Okay? So it's just that differential. So how many people do you think will have learning disabilities? Say you have a population of 1,000 people. How many people do you think will have learning disabilities? 50%. Ooh, that's very high. So half of this room will have learning disabilities. 20%. Okay. The answer is actually 2 to 3%. And that's because of that. And if you ask me a question, I might say why. But it's 2 to 3% of the general population. And they have a range of abilities and disabilities. So this population will have abilities and disabilities that are really borderline, where they're actually functioning, they're independent, they can get a job, they can drive, they can get married, all that sort of stuff, right through to the other end of the spectrum, where someone is really dependent on somebody else for all their basic skills and all their basic care. And so it's a real broad spectrum. And it's associated, or often associated, with lots of other things, like communication difficulties and understanding. Sensory difficulties, which are often not picked up. Hearing problems, eyesight problems, not picked up at all, even in childhood. Mobility problems, swallowing problems. And there is a huge amount of health need that is often unrecognised and undiagnosed. Sometimes related to the condition that causes the learning disabilities themselves, and sometimes totally unrelated. You also have a higher risk of mental illness. Now, we've heard talks before, there's a higher risk of severe mental illness like schizophrenia. There's a higher risk of autism is associated with it. High risk of dementia. People with learning disabilities tend to age prematurely. So there's lots of health conditions and mental health conditions. So one of the things we need to do is to try and identify people with learning disabilities in the population, and for that to then be entered into the GP records. Because once the GP knows that somebody has a learning disability, it opens up a whole new opportunity to actually say, well, you therefore need reasonable adjustments in your care, whether you're accessing health services or the ambulance service or A&E, whatever it is. And that you also have reasonable adjustments to access health screening services and health promotional material and advice. So it's really important. So I don't know how many of you have seen this, but we worked very closely with NENCAP last year and early this year for a Don't Miss Out campaign, really trying to encourage the person with a learning disability themselves and families to say, well, get yourself, see the GP, get yourself onto the GP register, because at least that way you can access all sorts of things. So Let me just give you some statistics. So in 2008, 2009, we had 27,000 people with learning disabilities on the GP register in England. 27,000 people. And they then had an annual health check because they were on the register. By 2016, 2017, that number rose from 27,000 to 140,000. So it's a huge jump. But it was still only 49% of those who were eligible to have one. So we've set a target. By 2020, we want 75% of people to have had an annual health check who are on the register. And we also want a 10% increase of those on the register. Because we know, as we've said earlier, that 2 to 3% of the population have learning disabilities, but probably only about a quarter of them are actually identified on any register at all, or any healthcare record. So we want to just sort of increase that, really. So last year we did an awful lot of work, as I said, with NCAP. We put in extra money to make sure that GPs are paid more, so that for each check they're paid for each check. We've worked with the National Development Team and the voluntary organisations to provide family and carer guidance, and we work with the Royal College of General Practitioners, again step-by-step guidance as to what you would do for annual health checks. And the other thing we did was that we created a national template for all GPs. And the national template for the first time includes not only physical health problems, but mental health problems, because we want to see the person as a whole, really. So my next question is, so how are we working to improve the health of people with learning disabilities? Because we know they have really huge unmet, unidentified health needs. And sadly, one of the things we do know, and I'm sure many of you will know, is that we have known for decades that people with learning disabilities die much earlier than their counterparts. And we know that, for example, 50% will die before the age of 50. And we also know from the confidential inquiry into premature deaths that they die between 15 and 20 years earlier than their counterparts. 15 to 20 years earlier. And 42% of them die from preventable, avoidable deaths. So some of this is due to just public health stuff, but some of it is due to quality of care. So that's a very big health inequality that we're really determined to tackle. So what we've got now as part of the confidential inquiry into premature deaths is the Learning from Deaths review. And they published their first report earlier this year. I don't know how many people saw it, which says even more staggering information. So now all deaths have to be reviewed in a systematic way. And the first report has found that women with learning disabilities, just this cohort, of course, not every death, died 29 years earlier than a woman without learning disabilities. It's staggering. And men were dying 23 years earlier. So much higher than we had originally thought. So this work is ongoing. We've now got in place in every single clinical commissioning group, CCG, in areas, we've now got a steering group that is focused on reviewing deaths of people with learning disabilities, wherever they are. And I know in your area you have Opening Doors, your voluntary, not voluntary, your user-led organisation, so they are co-chairing your steering group for this work. And what we also know from this report is that there are a number of things that are leading causes of death. So one is pneumonia. So what we've already done is we're putting on stream the Learning Disabilities Flu Vaccination Programme, which will be starting, which will reach into special schools, because special schools up to now have not had this benefit. The second commonest cause of death in this report was sepsis, which is one big cause in the general population anyway. So only earlier this month we had a big national workshop looking at good practice amongst hospitals in the country, and we've actually identified a lot of really good practice, and one of the problems is about sharing this practice and about teaching people about early warning signs, because often people do have signs but people don't realise the importance or the impact of these signs. And the third is aspiration pneumonia, so people actually breathing in stuff and it then causing pneumonia. And that's because of swallowing problems, feeding difficulties. So we're doing specific piece of work on dysphagia, which is the swallowing problems. We also know from various very sad reports and investigations about constipation being really big. It's a big cause of death, avoidable death, as well as epilepsy. So we know that 50% will have epilepsy as part of their health need. So we're doing very specific targeted work on this group just to try and really push the healthcare. The other thing that we're doing as part of the health programme is the amount of medication that people with learning disabilities are receiving. And by medication I actually mean antipsychotic medication, really major tranquilizers that is used mainly for schizophrenia. So in the general population, people who are known to their GP living in the community, how many people do you think out of 100 would be on this major medication for schizophrenia? 20. One. Okay, so the prevalence for schizophrenia is 1% in the general population, and actually what we find is that it's about 1% on medication. Now guess how many people with learning disabilities is on an antipsychotic medication?
100%?
Sorry?
100%.
100%. Well, every single person with learning disabilities on medication. 10%, 20%. Yeah, so actually, yes, it's almost 1 in 5. It is 20%, which is 17%, but you know, there's a staggering difference, and schizophrenia is 3 times more common in learning disabilities than the general population. So you might expect 3%, but you certainly wouldn't expect 17%. So why are they on medication? They're on it for other reasons. They're on it often to manage behaviours that people find difficult to manage. So that's one of the other things that we're trying to do at the moment. We've got a whole programme of work, call for action, called Stop Over-Medicating People with Learning Disabilities. So STOMP, we call it. And we've worked, again, very hard with a lot of families and carers in particular. The Challenging Behaviour Foundation is one of them. All our voluntary organisations, all our professional bodies have signed a pledge to work and to influence the way clinicians practice. And we've got a lot of quality improvement projects and research projects going on, and some people are in this room who are leading that work. So we've got that as part of our programme. Of course, the other really big piece of work follows from the Winterbourne View scandal. And I'm sure you all know about Winterbourne View and the really horrific abuse that people with learning disabilities faced whilst in care of a hospital. And so we have a 3-year funded programme looking at how we might, in particular, reduce the number of people who are admitted into a mental health unit, reduce the length of stay for those people if they are admitted, and improve the quality of community services so they don't need to be admitted in the first place. So that's a major piece of work. As I said, it's a 3-year funded programme. And it is very ambitious because, of course, the people who are now in hospital are the people that we couldn't discharge when we first closed the institutions down in the 1980s. So when we started the programme, there was something like 3,500 people in hospital. We currently have just under 2,500 people in hospital. And we're trying to, and we're very committed to, getting it down to 35 to 50% discharges. And so we published a national service model called Building the Right Support, and that's what it is that we're trying to build the right support in the community with people going into hospital only where they really need to, and then measure the quality of care when in hospital. And because of that, it's a partnership arrangement. We have to do it in partnership with lots of other people and lots of other organisations, but putting the voice of the person with learning disabilities and their families at the heart. Everything we do has to be co-produced. That's how we've started the whole programme. So I don't know if you know that there are 48 transforming care partnerships.